She's actually stuck at a meeting.
Oh dear. Oh good. Will you give her my...
Thanks for coming, guys.
Yeah, of course. Thank you for hosting this.
Thank you for coming.
Thanks for hosting.
Don't be shy. Ask questions.
Oh my God. That was unbelievable. And couldn't do it again. Hi, Frank.
How are you, Tony?
Hi, man.
What's going on?
He's just giving me some crazy news.
What? What's up?
One of my old clients passed away.
Oh, I'm so
And I
sorry to
didn't
hear
know
that.
that. So anyway, so you're running this thing, huh?
It's running me. I expect some pithy questions from you.
No.
Yeah.
You know
this guy, George Coleman, Tony Schiff.
Yes. Hi, George. You look familiar. Yeah.
So welcome. So thanks for being here, man. All right. We got Mark to tell you for the 50th medical. No, really, that's amazing. I didn't think he wanted to come, but he did. So I'm very happy to hear it. You guys are great here. Being able to see me again. What's going on, dude? It's all right. What's going on with you, man? Now we have a really bad, but I saw your name in. So you said you had. I got a weapon to play. Take a look at my buddy here. Peter Baker. He's here. He's doing network marketing and business development. We have famous people in the audience. I mean, we'll call you out. I'm here. So go Collins here. Sure you can. Right, let me have your latest card, will you? I didn't even load up the cards. I'm so retired. But I'm going to give you one. I can't find one. You're not retired. Don't lie to me. You want to be retired. Michael, the job's hired for you. I get out, but they keep pulling me back. That's me. Okay, let's see. Okay. Oh yeah, it would be. Plus I sit next to the lovely one else.
You can get us started.
Really? Okay. Are there more milling out there?
No, actually.
Thank you. Thank you, Eric. Was on? Okay, if I can have your attention, please. Is everyone in from outside? Let's drag them in and sit them down. Good evening and welcome to this latest session in the UCLA Health Forum, Narrow Networks, Changes, Issues, and What They Mean for Patients, Providers, and Health Plans. My name's Frank Matricardi, and we have a very distinguished panel for you tonight. You all have the handout, so their pictures are there. I'll read parts of their bio. They paid me good money to read a lot, so I will do that. And that's my younger twin at the bottom. The topic is narrow networks. Now, they're called narrow networks, contracted networks, which is kind of a misnomer, right, Shelley? Because every network's contracted. Select networks, tiered networks, special networks, whatever they're called, they're here to stay. And by the way, and I'm seeing my note now tomorrow, we want to welcome our live streaming audience, and you can put questions in on Twitter at #FSPHForum. I could barely get that out. So you can, if you're observing, if you're looking at us on live stream, you can ask questions that way. As I mentioned, narrow networks are known by a variety of names. They're not really new. They came out, I want to say, 4, 5, 6 years ago. And the reason why what we call narrow networks appeared was because of the demands of employer groups and other groups for more affordable health care. So a decision was made by the health plans that they had to have a
how should I put this delicately, a smaller network of quality providers. Now, last year, the Commissioner of Insurance tried to inject himself into the debate of narrow networks by pushing Prop 45, which fortunately for all of us got defeated. So with that, let me start giving you a couple of introductions for our distinguished panel. And that was a good segue for Shelley Rouillard. I'll read a little bit and then Shelley will be the first speaker. Director Rouillard is the director of the California Department of Managed Healthcare, which is the regulatory body for health plans in the state of California. California is unique compared to other states where usually the departments of insurance run things. Not here, except for a couple of early plans that were grandfathered in. All HMO activity, the capitated, the famous line, capitated prepaid monthly payment makes you an HMO, and therefore you're under Director Rouillard's jurisdiction. All HMOs, from Anthem to Care First to HealthNet, all the way down, Kaiser included. Shelley oversees health plans that provide healthcare services to more than 21 million Californians. As director, Ms. Rouillard is responsible for ensuring that enrollees receive high-quality care in accordance with federal and state rules. She came to DMHC with more than 20 years' experience as a healthcare consumer advocate and has contracting, network development, healthcare quality, and health plan performance. Prior to joining DMHC, she was Deputy Director for Benefits and Quality Monitoring at the California Managed Risk Medical Insurance Board. Previously, was a founder and director of the Health Rights Hotline, the first of its kind independent consumer advocacy program designed to assist consumers who have had problems with the healthcare system. And Shelley is a friend of mine, and she is extremely competent. We're very fortunate to have her here. Our second speaker is a guy who knows narrow networks, Colin Hayward. He's with Anthem. He's worked with multiple health insurance carriers in a variety of positions in his 18-plus years in the industry, the last 6 with Anthem Blue Cross. The positions he has filled include account management, sales positions, along with management responsibilities, including Director of Account Management. In 2011, Colin brought his experience and individual small group knowledge into his role as Regional Vice President for Anthem, for California individual and small group sales. And in January last year, he accepted the position of Vice President and General Manager overseeing California individual businesses. So he runs the narrow networks for Anthem. And Colin got his bachelor's degree in business economics from UCSB. We're giving him a waiver because he didn't go to UCLA. And our third speaker, an old friend of mine, and certainly last but not least, is George Coleman. For over 45 years, George, is that a cell phone? Please turn it off. I will confiscate it. For over 45 years, Mr. Coleman has been involved in representing over 100 healthcare providers in revenue recovery and business office consulting, assisting in creating on-site programs in public and private hospitals, as well as specialized insurance and third-party recovery programs. George is past president of the Southern California chapter of the Healthcare Financial Management Association, and I'm a member of that organization as well. And we also have Brian Mattson here, who is the 2016 incoming president for HFMA. George has lectured extensively and published many articles in areas of accounts receivable, legal recoveries, and business office issues throughout the country. Coleman is admitted to both the New York and California state bars, and he's also admitted to the U.S. Supreme Court, Federal U.S. District Court in New York and California, and the U.S. Tax Court. And George, as you can see, he's a New York boy, just like my wife is a New York girl, and he got his BA from Queens in New York and his JD from Brooklyn Law School. So, please join me in welcoming our first panelist, Shelley Rouillard from Department of Managed Healthcare.
Thank you, Frank. All right. Thank you. So I haven't practiced with this yet, so it's going to take me a sec to get this up. Thank you. Okay, I need a place to put this stuff too. Here we go. There we go. Thank you. Okay, hi everybody. I'm really happy to be here. I was telling somebody earlier in the hall that I'm actually a native Californian from West LA, so this is where I was born, and happy to be here to visit with all of you and to chat a little bit about the department and some of the work that we're doing around network evaluation, network adequacy. So what I'm going to talk about today is a little bit about the department broadly, so that you know a little bit about what we do, how we review provider networks, and then some of the activities that we're going to be undertaking around provider networks and directories. Okay, here we go. Good. So the department has just been going through a strategic planning process, and we have a new mission, and this is the mission, that the Department of Managed Healthcare protects consumers' healthcare rights and ensures a stable healthcare delivery system. And we do that in a variety of ways, which I'm going to talk about now. But first and foremost for me as a consumer advocate is that we are there to make sure that people get the care they need when they need it, and we hold the plans accountable for providing the care that they are obligated to provide under their contracts with employers or with the state or with whoever the purchaser is. So the department was established in 2000 as a result of consumer-sponsored legislation. It was during the Gray Davis administration. The department's funded solely by assessments on health plans. We don't have any state general funds, so our budget is developed and then we assess the health plans accordingly. We regulate managed healthcare plans, both commercial as well as government lines of business. There are 70 full-service health plans and 52 specialized health plans that we regulate. And that includes, as Frank mentioned, all HMOs. We have a number of PPOs, EPOs, which is exclusive provider organizations, which is kind of a new thing recently. Large group, small group, individual, and then government Medi-Cal business. There's approximately 400 staff in the department right now, and that's going to be growing if the positions that we've put forth in the governor's budget actually go through. Because as you'll hear a little bit later, there's a lot of new activities that we're going to be undertaking around networks and evaluating them and determining whether they're adequate or not. The authority for all of the work that we do comes from the Knox-Keene Healthcare Service Plan Act of 1975 as amended, and it gets amended every year. And there will be more bills this year that will amend the act, and we'll be implementing those as they get signed. So just briefly, a few of our key functions. First and foremost is our Consumer Help Center. Our Help Center assists people who are having difficulty navigating the healthcare system. If they've been denied care, they have delays in getting care, they can't find a provider. It's really geared towards people who are in a health plan already. We don't really deal much with eligibility issues. Those tend to be, those are generally referred elsewhere. We also act as the federal consumer assistance program. When the Affordable Care Act was signed, there was a grant process for consumer assistance in all the states. And our department was determined to be the consumer assistance program. So through that grant, we contract with a number of legal services programs throughout California to provide locally based assistance to folks in their communities. So I'm really proud of that. Our plan licensing division does what the name suggests. It licenses the health plans. It looks at all aspects of health plan operations, the networks, how the contracts between providers and the plans, what the quality of care grievance and appeals systems are, the organizational structure, et cetera. Once a plan is licensed, every 3 years, we have a team of folks that go out and do the surveys of the plans to make sure that they are complying with the law and also with the policies and procedures that they filed with the department so that when they say they're going to do things a certain way, this group goes out and makes sure that they're doing them in the way that they said that they would. There's two different kinds of surveys. One is what we call the routine, which is the one every 3 years. And then there are non-routine surveys. When an issue comes to our attention that needs further investigation, we have the ability to go into the plan and take a deep dive into that. And I'm going to be talking about one of the ones that we've done recently related to networks with Anthem and Blue Shield. Financial oversight looks at the financial solvency of the plans, whether they have adequate cash reserves, whether they have their ability to pay claims timely, accurately, and that they have the financial means to be able to provide the services that they're contracted to provide. We also do review the financial solvency of medical groups, capitated groups that take on risk. And there's about 190 what we call risk-bearing organizations, which are really just another term for medical groups. We also conduct premium rate review. Rate regulation was the subject of Prop 45 that Frank mentioned, but although the department doesn't have the authority to approve or disapprove premium rates, we look at the assumptions that the health plans have made and determine whether or not the rates that they're requesting are justified or not. If they're not, we can find them to be unreasonable, and oftentimes we'll be able to negotiate a different rate with the plan. Sometimes we can't. The plans can go ahead and implement those rates, and then we post on our website that we have found a particular rate unreasonable. We also look at the annual medical loss ratio, which is the percentage of premium that goes towards medical care. For the large group market, it's 85% of premiums need to be used towards medical care or quality of care activities. In the small group and individual market, it's 80%. And then last but not least is our enforcement team, and they do what the name suggests. They go out and make sure that when the plans aren't following the law, that we have enforcement mechanisms, which include penalties, corrective action plans, cease and desist orders, whatever. Okay, so let's get to the heart of what we're talking about today. These are the topics I'm briefly going to cover, so we'll just leap right into network adequacy. As Frank mentioned, narrow networks, it's kind of a pejorative term these days, you know, people can't find the doctors that they want in the networks, but really narrow networks in and of themselves are not new. HMOs historically have contracted with a limited set of providers in a particular area, and now the PPOs are doing that more and more as a way to be more competitive. So we consider networks adequate if they meet the legal standards, which are these elements that I have up here. Geographic access. Are there adequate primary care physicians and hospitals within 15 miles or 30 minutes of the enrollee's homes or workplace? This is standard as a guideline, so in some areas like the rural areas where there may not be as many providers available, we're able to work with the plans to approve what we call alternate access standards. Specialty physicians, the access must be reasonable. So we do look at ratios of specialists. Do they have a range of specialists that are going to meet the majority of needs that occur with a health plan? Also, similarly with mental health or ancillary care, that it's a reasonable standard. With regard to provider capacity, the primary care to enrollee ratio of 1 full-time equivalent primary care physician for every 2,000 enrollees. That ratio can be increased by 1,000 enrollees for every physician extender, nurse practitioner, or physician assistant that the primary care physician has in their offices. For specialty physicians, the overall physician to enrollee ratio is 1 to 1,200. No specific ratio for just specialists. And then we get into the area of timely access. And this is a regulation that sets out specific time-elapsed standards that people are supposed to get access to to care within. So for primary care physicians, appointments for non-urgent primary care must be offered within 10 days from when the enrollee requests it. For specialty physicians, it's non-urgent specialty care is within 15 days. And then for mental health or ancillary care, again, it's 10 days from when the person made the request for the appointment. Urgent appointments that don't need prior approval must be offered within 48 hours. And for appointments that do need prior approval, it's 96 hours. Rural access, of course, is a big issue. More and more folks in the rural areas are now are in managed care plans through whether it's through the individual market of Covered California or in Medi-Cal. And so one of the things that we look at in determining whether the access is adequate or not is kind of what is the pattern and practice of the area? Like, do people historically had to travel, you know, over mountains or big distances, or sometimes in the counties that are next to another state, you know, Oregon or Nevada, sometimes the individuals will go to those states for care. So health plans can demonstrate geographic access by requesting an alternate access standard and proposing how they're going to meet the standard if a particular hospital or if a hospital is not within our standards or there aren't enough physicians or specialists. So we do consider a number of factors, including the overall population of the county, the availability of providers in that area, and what the plan's contracting efforts have been with providers in that area. We also look at telemedicine and telehealth activities that the plans undertake as a way to expand access for their enrollees. Okay, so something new that the governor signed, SB 964 last September, which adds new requirements for the department in terms of looking at networks and whether they're adequate. So we have a lot of new work ahead of us to annually review and assess all full-service health plan, that's all the health plans, and behavioral health plan networks. Every year we're going to be looking at them and assessing them and determining whether they're adequate. We are also required to standardize the health plan reporting of compliance with timely access standards. So measuring timely access is really, really challenging, as any plan representatives here will attest to as well. And when the regulation was passed, there wasn't a set methodology that the department told the plans, you need to do this. And over the last few years, we've been kind of working with the plans and trying to tweak the requirements for reporting compliance, but it's been a slow process. And without a standardized methodology, you can't really compare how plans perform against each other. And that was one of the goals of having the timely access law to begin with. So we have 5 years to adopt a standardized methodology. We're not subject to the traditional rulemaking process. So it gives us some flexibility to work with the plans, to try different things, to see what works. So we have 5 years to do that. The plans do submit annual networks to us through their timely access reporting, which occurs in March. So just to give you an idea, we're going to be looking at these networks by plan, by product line, so HMO, PPO, point of service, EPO, by county, and we're looking at like over 3,000 reviews of networks in the coming year, because each plan is a little bit different networks, as I'm sure you'll hear about later, and looking at it by county, it's just extremely challenging and a huge amount of work. Eventually, the plan's compliance with timely access will appear on the annual report card that the Office of the Patient Advocate puts out each year. Okay, so back in beginning of 2014, between January and May of 2014, the department received a lot of complaints from consumers about not being able to access the providers that they thought were in their networks because they were listed on the directories that they got. And this was primarily in 2 plans, Anthem Blue Cross and Blue Shield. So the complaints basically alleged that they couldn't find a primary care physician, or had been told that the physician that they wanted to go to was in the network, only to find out that that person wasn't. And they felt that they'd been misled by inaccurate health plan provider network directories. So we did a little investigation in a few counties and determined that there was enough of a problem that we needed to do a non-routine survey, which is where we go into the plan and we get information from them about what their provider directories, who the providers were listed on those, and then we did a phone survey and called random samples in all 58 counties. The long story short is that these are some of the key findings, that in both plans, about 25% of the providers either were not at the location that was listed in the directory, or they were not accepting covered California products. So this was unique to the individual market, which was the only area that we were looking at the time. You see the percentages differ a little bit in the 2 plans, but overall it's about 25%. So this is quite significant, and it clearly is a problem, and these deficiencies have now been referred to our Office of Enforcement to determine what we're going to do about it. To their credit, the plans have recognized that, yes, they had some problems, and they've been doing a lot of work to verify their providers' participation in the networks. Both plans said that 99 or 95% of the providers actually do have contracts. So there's a lot of issues with what do the providers know about who they contract with and for what products, as well as the accuracy of the directories themselves. So They are, as I said, doing corrective actions, and they've been doing provider outreach campaigns, updating their directories, and so we're going to be doing a follow-up survey in May to check on the activities they've been doing, their corrective actions, and how well they have performed, and whether or not the directories are correct, or more correct now. Because frankly, I mean, let's face it, directories are going to be out of date the minute you publish them. So there needs to be a certain threshold of accuracy. 25% inaccuracy is not okay. SB 137 by Senator Hernandez was just introduced this week. It deals with putting standards in place for provider directories. So this will be going through the legislative process, and depending on whether it gets through the legislature and the governor signs it, there may be more work for us to do on this. But right now, as it's been introduced, it requires insurers and health plans to update their provider lists weekly and make that information available online, to post online whether in-network physicians are accepting new patients, and publicize what languages the physicians can serve people in. So with that, if you need help, or anybody you know needs help, they can call the Health Rights Hotline, the DMHC Help Center. There's our contact information, and I look forward to your questions. Thank you.
Thank you, Shelley.
Okay.
Thank you very much, Shelley. So our next speaker, please welcome Mr. Colin Hayward from Anthem Blue Cross, who's out fixing all these problems that Shelley's.
Perfect. Well, before I begin my presentation, I just want to set the record straight. So I am a gaucho. I went to UC Santa Barbara, but my father and my father-in-law were both Bruins, so I'm sort of a legacy Bruin that way. Yeah. Well, again, my name is Colin Hayward. I'm the general manager over the individual business for Anthem Blue Cross here in California. I want to thank you. I really appreciate the opportunity to speak here tonight. Obviously, the neural network topic is something that has been really a hot point of conversation for us in the individual market as well as all markets. We've been working closely with our regulators here. We spend a lot of time internally talking about it, externally talking about it. Today, what I'd like to do is just sort of give you a brief overview of really what the neural network is from a carrier perspective, talk about some of the different things we look at. Is it a new phenomenon? Those types of things. So I'll just jump right into it. I know we're a little crunched for time, so we'll move forward. So what is a neural network? Now, a neural network really would be defined as just a smaller version or a subset of a full or broad network. And I think this is an important piece to focus on for a second. Many people come to the carriers and ask, where are you finding all these new providers to create these new neural networks from? Well, the reality is these are not new providers. These are the same providers you have in your full network. We have just narrowed our options for different reasons to offer a select or a narrow network version for all of our consumers or employer groups in the marketplace. I also got the question of, how small is your narrow network? It's a question that we get pretty frequently. I'll speak to the individual network we offer in California for Anthem Blue Cross. We have tens of thousands of providers in our EPO and PPO provider networks throughout California, and that's from San Diego all the way up to Eureka on the borders. So it's not a very small network. I would say it offers a lot of flexibility, a lot of choice to our members. I think some members were used to seeing any provider out there. This does not afford you that capability, but it still offers the flexibility of seeing many, many providers throughout California. I will focus on the LA market in general really quickly. When we look at LA, there's third-party studies. We've got thousands of providers here in the Los Angeles area, some that you're really familiar with, and I'll touch on those in a moment, but really well-known provider groups that many people have heard of as well. So neural networks, are they a new phenomenon? And I think Frank, Shelley touched on this previously. They're not a new phenomenon. We've been offering neural networks in the group environment for years, primarily on the HMO products. However, Anthem Blue Cross, we have had PPO products in a neural network version, at least in the group side. So they've been around for years. Groups have been demanding that we offer more affordable options to them. Narrowing our networks is one way we get there. We've seen the membership growth rate on our narrow networks be significant. One carrier, I won't mention my name, but referenced last year at a health underwriter event that their narrow network HMO options actually had more membership than their full network options. So it's a very popular option. It's growing in popularity. The market's demanding it from us, and we're trying to meet those demands. Oops, sorry. So why do carriers narrow their networks? And I touched on it a little bit, but market demand, price sensitivity are something we are very aware of, very conscious about. We consistently get questions on the sustainability of the premium increases we offer to the marketplace. If you go back in history a little bit, late 90s, early 2000s, it was not unusual to see a 20% or more increase year over year. Those types of increases were not sustainable. Narrowing our networks for employer groups, for our consumers, was one way we could control some of those pricing trends. We could get immediate pricing breaks by narrowing the network, as well as control some of the pricing trends for future years. So it's something we looked at very closely. We continue to work very closely with our provider groups to make sure that we're aware of their needs, as well as our providers, our employer groups and consumers as well. Finally, the last question I have here is something that I always like talking about. So, do narrow networks equal low quality? A lot of people come to us with, you just basically throw all your low quality providers in there. First, I would say that every provider we have contracted with Anthem Blue Cross has to go through a credentialing process. That credentialing process would include some quality metrics. So we would consider all of our provider quality providers. However, to go a little further, we don't just have the independent physicians, the mom and pop shops from around the state. We have very large provider systems that I think a lot of people would focus on as being high quality. I'm stepping on campus right now of one of those provider groups we offer in our PPO provider or EPO provider list for individual. So UCLA is part of our network. We also offer Cedars just down the road here. Two very big brand names in the LA market as far as being associated with high quality. If you look around the state, we have UCs, we have Sharptown in San Diego, a number of children's hospitals. So I think it's a far cry from being a low quality network. We're really just trying to focus on keeping the costs down for our consumers and our employer groups. Now, narrow networks within the individual market, this is a fairly new phenomenon. And I think the Affordable Care Act has brought light to a lot of the narrow network topic. So in 2014, we launched a lot of our new Affordable Care Act products and networks in the individual market. What we had to do here, though, is we had to meet standardized product offerings. So the actuarial value tables, if any of you are familiar with it, by metal tier. So your bronze metal tier has to be a 60% actuarial value, silver at 70, gold at 80, and platinum at 90. It doesn't offer a lot of flexibility for carriers to make premium adjustments. One way we can get there is by narrowing the network. We did a lot of research and analysis prior to 2014 to identify what were going to be the purchasing points for the new consumers. Price was something that came up in every single discussion. We looked at it from here to Sunday as far as how we got to the price points that we thought we could bring quality providers to the markets and still get to a price point that people would purchase. In addition to that, you have some new entrants into the market. So a lot of people who had never purchased insurance before, a lot of people who were uninsured previously on the group side, maybe couldn't or had health conditions that they could not get underwritten in the individual market. A lot of these new entrants were coming in. With these, they had subsidies that were available to them, new insurance requirements that they had to have insurance or face tax penalties. All of this led to sort of price discussions. Now, especially when you look at some of the previously uninsured, they didn't have providers that they were seeing previously. That choice wasn't something that was one of their primary reasons for purchasing, but price always was. And I think if you look at the first year results, 2014, working with Covered California here, if you look region by region, the low-cost option won in most situations. It's the reality that people are looking for price, especially with those subsidies. If your subsidy brings your cost share down to $20 or $30, you need an affordable product that people can purchase and keep on the books. Other avenues we look at, and Shelley touched on this a little bit, but some telehealth options that we look at in our individual market. This is also offered in our group side, but I'll focus on the individual for a second. So in our PPO and EPO products, the metal tier products, we have a telehealth option for our members. So we use Live Health Online as the tool we use for Anthem Blue Cross. But basically, through your smartphone, your computer, your tablet, you can access credentialed providers with Anthem Blue Cross for an office visit over video conference. So it's something new to the market. We haven't seen a huge uptick in utilization yet. We're starting to get some results back now, but it's something that's taking off, but it gives a really quick access to our members to see a credentialed provider. And I will say, there's a lot of people shake their heads when I talk about the telehealth option. Of the people that actually have used this option, the satisfaction rates are higher with the telehealth option than they are in actually going to see a doctor in his office. So it's something we're pointing to. It gives great availability. The wait times usually hover around 8 minutes. So you could try calling your doctor and getting an appointment in 8 minutes, and I would challenge you there. So it's something that we really are looking at as far as sort of the next wave of offering full provider options to our members. Finally, there's a few key points that I'd like to leave you with. So narrow networks, they're not a new phenomenon. I think they've just gotten a lot more attention with the launch of the Affordable Care Act in 2014. I don't think they're going away either. Obviously, their popularity is something that has continued to grow. I think based on the price points, the pricing trends we've seen, especially after the first year of Covered California, average increase is about 4%. We are doing fairly good work on keeping this affordable for our consumers. Market demand and premium sustainability have driven the need for narrow networks. So we're hearing from our market, our groups, our consumers that they want affordable coverage. They are okay with the narrow networks. We have a lot of quality providers within those narrow networks, and it's something that they're willing to purchase. And that's really where I'd like to end it, that the high quality providers are something that we will continue to focus on. We'll look at potential expansions where we can. But we're going to work closely with our provider groups, our regulators, to make sure that we're offering the quality care our consumers need. So I look forward to the questions. Thank you.
Thanks, Colin. Please welcome George Coleman from Stevenson, Akisto, and Coleman.
Thank you, Frank. Well, I was told that I may have to do this from the consumer perspective, and it was very nice to hear from Shelley and Colin on what they see is happening. In my representative capacity of providers and sometimes consumers, firstly, I want to say all 2,000 pages of the Affordable Care Act are not bad. Despite the furor and the political suicides and the swearing and all that stuff, we can't throw the baby out with the bathwater. 48, 49 years ago, I was in law school when Medicare and Medicaid went into effect. And I can assure you, those of you that were there, it was not less and was probably more intense than what we're dealing with the Affordable Care Act. As a matter of fact, there's still a lot of changes going on that are daily. We heard today that Indiana, a Republican governor, jumped in to the Medicaid expansion. So we have 13 hospitals 13 states that jumped in within the last year or two that had not considered jumping in. In addition, United Healthcare, which didn't want to participate in the Covered California program, declared the fact that it now wants to participate in the Covered California program. So I guess Shelley's department doing a good job, and they see there's an opportunity to make money in the program. Now, I only have 10 minutes to go through a lot of stuff, so I'm basically going to talk about the Covered California and the Medicaid expansion, but more so Covered California. Most of the plans that I'm involved with and the providers I'm involved with have direct contracts with the plans. So some of the issues of access we don't necessarily see. What I'm more concerned about is the Covered California, which interestingly enough, they were going to call Avocado. The original name of Covered California was going to be called Avocado. I mean, this is California, right? They call Medicaid Medi-Cal. We got to be different out here. So, and that's true and funny at the same time. What the problem is here, as I see it, is that the difficulties in access to coverage and the various programs with the particular networks. Now, what I like to call the Olympic plans, because you have the bronze, silver, gold, platinum, and they all have variables. But very interesting, with all the complaints we hear, many of the people that are in the Covered California plans are very happy with them. They're very satisfied. They're actually paying less than they were before under their own individual plans. Now, we're not going to discuss group plans through the employers. We all know what they're about because many of them have them. So I'm talking about the individual plans, these people that are now required to get insurance and required to apply for the plans. And hospitals, interestingly enough, because of the amount of covered California, have more insureds in their hospital and there's substantially less charity care that the hospitals are having to deal with. So the covered California plan seems to be working, but it's still very new. And it has a lot of roadblocks. And some of them, despite what Colin said and Shelley said, and they're new to investigating it, we have a lot less clinicians than we did before. And even though we had narrow networks, these particular narrow networks are a lot less and smaller. As a matter of fact, we have 35, I believe, Shelley, you can jump in, 35 to 50 clinicians per 100,000 people. The federal government standards is 60 to 80 clinicians for 100 people. I mean, I venture to say that in order to get more access, PAs, LPNs, chiropractors, pharmacists are going to, at one point in time, start to get involved in testing and doing all the things that might be necessary for clinicians. You also see today that many of the providers, Sutter Health, Kaiser, and some of the others, have affiliations with some of our retail stores which have clinics. Rite Aid, Target, CVS. I think UCLA has a relationship, either CVS or Rite Aid, I'm not sure, and Walmart included in that group, to provide more clinical expertise out there. One of the problems is also the inability to produce primary docs and to have more primary docs available. One of the reasons is that if a doctor's lucky, after 2 years they're earning $150,000 and they have debts to pay off of anywhere from $300,000 to $500,000. So they're not necessarily venturing into primary care. And that's probably a major source. The inaccurate directories that we referenced earlier are true to much of an extent. And a lot of it is not only plan generated, but provider generated. Many of the doctors, in all due respect to those of you who are here, the operations of your business offices are not as well run as one would think, and many are not even aware of the plans they're in. And if you talk to the office staff in many of the physicians' offices, they're not sure of what plans they're in. And if they're in a Blue Cross plan, they may not know what particular plan they're in and what benefits are available. As a matter of fact, I'll give you an incident for a particular patient who needed an MRI and was directed to a particular hospital who shall remain nameless. The services were authorized and arranged to the hospital with a specific date. A little before the date of the visit, the plan called and said that the services is no longer authorized at that hospital. We have a contracted provider that you must go to, which was 30 miles away from the patient's residence, where the hospital he made the original appointment was in 15 minutes of his home. And that's an issue. That's an issue of access. And that's a concern because most contracts, if not all of them, and some of the laws dictate that you should be able to have a provider within 30 miles of your residence. One of the difficulties, of course, is rural communities where it's even difficult to get specialists. But that's another problem with access. So that's an issue. Patient education makes it even more complex. I don't know how many of you can pulled out your most recent insurance plan and policy and read it and understand it. I went to school for 19 years of my life. I deal with healthcare all the time, and I'm telling you, we reinterpret and interpret and reread our plans all the time when they involve the claims that we're dealing with. They're very complex and very difficult to understand. And I can tell you right now, I don't know how a lot of the members and beneficiaries of these plans understand all the things they have in it, particularly the fact that the formulary changes every January, so you don't even know what drugs are covered and whether or not you get new drugs. So the education factor, which Shelley's department has to deal with, is the fact that a patient's taking one particular drug one year, that works. And then all of a sudden January comes and they have to take another drug. And it's very difficult for people to understand, but that drug was working for me. Why do I have to switch? So there's a lot of misunderstanding out there and a lack of education that contributes to what I call access. Behavioral health is a major issue for access. Able to get an appointment for behavioral health, any type of psychiatry or psychological testing, is very difficult. The access is not readily available. Matter of fact, Kaiser, I think, is under the gun right now because they have a difficult problem with behavioral health. Getting access to information through agents. There are 12,600 insurance agents in California that are available to help people become eligible or get enrolled in different plans. I want you to know that communication with the departments in the state sometimes take as much as 30 minutes to make contact. In addition to that fact, 2,000 of them, as of about a month ago, were owed over $2 million for a period of 6 months for their fees. So not only is the individual insured trying to have access, they're trying to employ people that can't get paid for the services they're supposed to rent. Another problem is bait and switch. Very often in the presentation of an insurance plan, I don't really mean it from an inappropriate way, but the idea that it's not explained to the particular applicant very well. So they go home and they think they have a particular plan with certain types of benefits, and they find out later when they go to a hospital or a provider that those particular benefits are not there, or their copay or deductible is a lot higher than they thought. As a matter of fact, the deductibles are a lot higher because hospitals are dealing with an increased self-pay problem, including UCLA Medical Center, because of the higher deductibles. The other issue is sometimes the network, the particular network, may not be with a particular provider. Although most providers are in most networks, you do have a situation where an insured is taken to an emergency room for a particular illness or condition that requires emergency care. And every hospital, every provider must treat, regardless of what the finances are, regardless of what the benefits, regardless of what the insurance is. That's both under our state emergency regulations as well as federal rules under EMTALA. After the patient stabilized, they are allowed to ask questions and information relative to insurance. Well, what sometimes happens, we find out that that particular plan is out of network, and it registers a concern with the hospital whether or not they're going to get appropriately paid for their services or something less. And so you run into a problem of an out-of-network situation. And it's possible, if it's less, and the hospital doesn't appropriately appeal it or move forward on it, that the patient may get stuck with paying the bill that would otherwise be the responsibility of the plan. I talked about rural assets, I talked about formulary charges. One of my biggest concerns is social services programs. One of the things we do not do in this country is fund the social services programs. And I don't mean the welfare issue, I mean education, I mean reducing crime, and I'm talking about housing. If we can put more money into those particular circumstances, I think it would reduce the impact on health care. Educated consumers, less crime, and people who live in suitable housing are less likely to have health care problems than others. So that's another place we need to look to lower the cost of health care. I got 1 minute, and in conclusion, I can only tell you this: it's going to get better. Thank you.
Thank you, George. Thanks to each member of the panel. That was great. So we have some time for questions, and I know you got a million of them. So should we, let's see a hand. Someone yell something out. Yes, sir. Oh, come up here and sit. That's right. The panelists are all there within throwing distance or shouting distance. Yes, sir. Ira, is that you? Yeah. No, go ahead.
My question is for you, ma'am. The thrust of the rationale for the narrow network is alleged to be affordability for the consumer. Yet the consumer, if they have to go out of network, winds up paying a substantially larger amount of the cost attributable to the services that that patient needs. What I'm interested in is the regulatory oversight of your agency, specifically as to the financial, if you will, goods that the carriers are representing. For example, I think we both know that individuals pay much more for insurance coverage of the same quality than people in large groups. Small groups also pay more than the people in large groups. We also understand that the medical loss ratio in a large group is 85%, which means they, of course, have to spend 85% of the dollars they collect on actual health care. But for that individual, they only have to spend 80%. So the allegation that there is a cost savings that's being built in here, is that something that your department will look at? Because I personally am very suspicious of that.
Okay. So let me see if I understand what your question was, which I think it started out with people have to go out of network if, and what is the responsibility of the plans to cover out-of-network care? If,
And also, they're justifying this, that they're offering a big premium savings. I'm not sure that that's true, or I'm not sure that it's true to the extent of the cost shift that they're making when somebody does need services outside of the network.
right. So in the department's review of the networks and the services that are available by the plans, part of what we do is make sure that all of the services that are going to be covered through their plan, and we'll just use covered California individual market as an example, standardized benefit plans, so the standardized benefits. So the plans have to show us how they're going to cover those services in network. The issues come up sometimes when there's a certain kind of specialty, like a subspecialty. Somebody needs a certain kind of high-level care that may not be available generally. If it's not available in network, then the plans, and it's medically necessary for that person, then the plans are obligated to cover it out of network. The issues then come up with how do the plans negotiate what the rate that's going to be paid to the provider, and that's the source of a lot of tension between the plans and the providers. There's also situations where somebody goes out of network on their own because they want to go to a particular provider who may be not in network and haven't gotten approval from the plan to do that. In that case, then the consumer is on the hook for the difference between what in a PPO, what the plan may pay and what the provider's billing. So it really, what consumers have to pay really depends on the relationship, the type of plan they're in, number one, but also the relationship between the plan and the provider. When it comes to emergency services out of network, though, the consumer is not on the hook for any difference between what the plan pays and what the provider charges. That's a dispute that is solely within between the plan and provider, and our department has taken enforcement action against providers that balance bill of patients because they're not getting what they think they should be paid by the plan. So I hope that addresses your question. So.
Right, so as a follow-up to what you just said, and also bringing in individual plans right now offered through Blue Cross, Anthem, the EPO plans specifically. Let's say, my understanding is at this point, someone who has an EPO, they will not have access to any outside of California coverage at all, network. There are no network providers for outside of California under individual plan. Going back to both George's and your comment right now, let's say if someone is traveling to New York and they need to utilize emergency services. That's
They can.
They're admitted to the hospital and now they're stable. But there is continued care requirement, as George alluded in his comments there. What happens then? Because do they have to be transported to a California hospital right now? Will Blue Cross, for example, or does your department in any way, has your department looked into that situation? Situations where there are these loopholes that would leave the consumer with these deep liabilities.
So there is a requirement for what they call post-stabilization care after an emergency, and the treating hospital and the plan need to work out between them at what point that patient is stable enough to move them back, in your case, across the country. So we do monitor the plan's post-stabilization care, and that is also a source of dispute oftentimes, because sometimes the treating provider, the hospital, will say the person needs to stay in longer. The plan says no, they're ready to come home, and then that's where the dispute comes in. And those kinds of situations our department would like to hear about if there are problems and somehow the patient's getting stuck in the middle between that. But it is a tricky situation with.
Yeah, I would just say, we do offer the emergency coverage out of state, so, not having access to our Blue Card, which is our national provider network, is true in an individual market. It's difficult to answer as far as the stabilization of a patient after emergency services. There are going to be unique situations that our medical directors would have to review. So I can't speak more in global terms. We'd have to look at more specific cases, and we would work with the department on those types of situations as well as with the provider. So it's difficult to answer in a general term, but we would look at it really closely and want to work with our department to make sure that we handle it appropriately.
Yeah. First of all, I want to say something positive about Blue Cross right now. Because they're the Blue Card, because it used to be Blue Cross Blue Shield years ago, you remember, and Empire, New York, and all that, they're all tied. Because of the Blue Card, it's most fortunate for a lot of people that if they come from another state to California, or California to that state, that Blue Cross will definitely positively look at the coverage based on that. The dispute as to what they will pay or anything becomes a provider plan issue, and that can be a dispute. But rarely would Blue Cross deny services once the patient is stable in an emergency environment. I also want to add that in California, the law, they have what's called the half-hour rule or the 30-minute rule, which means once a patient is stabilized for transfer and the emergency has ended, the provider has 30 minutes to contact the plan to get authorization to continue to treat for medically necessary services. If the plan fails to respond, and it's got to be available 24/7, they continue to treat as medically necessary, and the plan has to pay for it until such time as the plan, learns about the particular services through case management or UR.
Yes,
Yeah,
Dr. Schwartz.
okay. I'm a provider, and in our office, we've done fairly well with cash-paying patients who have covered California who can't find care elsewhere. We practice in an affluent area where very few practitioners will take covered California. We have asked to be a member of covered California, interestingly enough, and we've been denied, and we're not told why. We don't know the criteria for selecting doctors in a narrow network. We suspect we don't know what it costs of service, we have all the qualifications for your other products in your plan, but not the narrow network. So how do you choose doctors for your narrow network?
We'll start with this. I'm not an actuary, and this is going to be sort of getting into an actuarial discussion. But what we look at, generally speaking, is we're going to look at efficiency scores for our providers. So basically looking at sort of similar episodes or claim conditions and the total costs associated with similar claim conditions from provider to provider. So we'll look at efficiency scores there based on total costs of those providers or physicians or hospitals, medical groups. So a number of different things we would look at there. I'm not the actuary, so I can't get into specific efficiency scores. That's part of it. Some of it's just our general contracting terms from provider to provider. So I'm happy to have the discussion and get our network team involved. We do have a provider contracting team that would have these discussions directly with you. But it's gonna vary by region. It's gonna vary by provider specialty. Well, there's different versions of what they're going to look at. Some of it's different contracts by provider group or by physician. What we'd look at specialty, and then there's going to be total cost of care that we're going to look at as far as the efficiency scores those providers have. So there's going to be sort of a multiple view that we're going to look at when we have those contracting discussions. But again, it's I can have our contracting team contact you and we can work through it. I don't know where you land or what specialty you're in. Yeah, that's generally speaking, we would look at those functions.
Hi, Dr. Richard Singerman. I'm currently working on an HHS-funded initiative for basically enhancing the availability of evidence-based medicine resources to community healthcare workers and social workers. So my question is, especially in these narrow networks, it kind of alludes to what George was referring to earlier, how much is there an outreach to the community healthcare workers, to the social workers, to, in general, these ancillary services and sources of care beyond the traditional, the hospital and the ambulatory docs?
We do have certain requirements on essential community providers that we have to reach out to. We're constantly actually working with them. Covered California has specific requirements for us in the individual market. So we are reaching out to the community providers pretty consistently. We actually have a task force right now assigned to it. So we're looking at signing the appropriate amount of community providers throughout the state. So it's a constant battle for us trying to get outreach to them, communicate with them, and actually contract with them. But we have a task force assigned to it right now.
My question is, one of the motivating factors behind the Affordable Care Act was that if we had many more insured people and the hospitals were compensated for the uninsured, that there wouldn't be this cost shift onto those who do pay for insurance. So my question is for the doctors and hospitals, when is that medical insurance dividend going to come back and reducing your fees, I guess? You're the Dr. George?
Yeah. You know what? That's a great question. Next question. I don't have, Karnak. I don't have the.
But they have now. They're getting paid. They're being paid. They're being paid. Shouldn't their reduced fees come down?
Well, and they just took away a subsidy in the Medicaid program. Do you know a physician gets $11 per visit under the Medi-Cal program? So, and because they have more patients now, because there's more people covered, there's a volume issue for the physicians in dealing with the number of patients. And I think what we have to do so that they can get you guys can get the benefit, is maybe have more people involved in the clinical decision making than the physician directly. And that becomes an issue for a lot of things. There's also the issue in California, and I know Tony's here shaking his head, the corporate practice of medicine, which restricts in many ways the ability to doctors to be employees of providers. And they create these very complex foundations to take care of this stuff. And so I can't say that totally answers your question, but built into the ACA is a bonus program. When it becomes effective, I don't know. Now, the ACA will go on, is still operational through 2019. And there's still a lot of stuff that's going to be changed and modified and implemented. There's an administrative simplification procedure that's probably going to be implemented that's going to have more uniform billing standards. So the bill from Hospital A and the bill from Hospital B to Carrier C and Plan D will be the same. Right now, it's all over the place.
My question is for Colin, and I was curious how the company is approached with these narrow networks, either parallel or intersect the Vividity network, and Anthem's approach with bringing providers together for a more integrated approach. Do they connect, or are they?
They connect really broadly, I would say. Vivity on its own is probably, you look at it, it's a narrow network option for us. Vivity, basically we're working with 7 of the major hospital medical groups in the Los Angeles, Orange County arena for large group insurance, which basically would offer an HMO coverage to members at these top 7 medical group hospital-based organizations. But it's a shared structure. So Anthem Blue Cross, we are the administrator, but we would work directly with these 7 provider groups in LA, Orange County. So it's, if you want to look at it, it's pretty narrow on what we would offer. That's more of a shared operational structure. So they have a board of directors, founders that actually would help us in the decisions. They are going to be basically referring from provider group in theory on how they would actually handle it. The narrow networks that we're working on, individual, small group, they're a little separate because we actually administer them. We would look at the different ratings that we want to on who we actually would participate with to bring the affordability levels down. Sort of a separate entity altogether, and really it's just a large group pilot that is out there that we think can be successful in working hand in hand with the provider groups as opposed to us handling the administration of it.
Everybody consists of UCLA, Cedars, Torrance Memorial, the Memorial System, and Long Beach Presbyterian Community. I'm forgetting the last two. Huntington, that's right. How could I,
Good Sam.
how could I forget those two? Yes, okay. The jury is very much still out on it.
It's too new.
Yeah, it's
Too
brand
new,
new.
right.
It's been a couple months,
Right.
January.
Yeah, this is it. So January 2015 is when it was launched, essentially for our large group offerings. So it's brand new.
This gentleman.
All of the systems did agree to offer lower rates, so that was the hope of this cooperation.
Right.
And ownership will work.
Correct.
This gentleman is.
This question is directed towards Mr. Havard. I'm an agent, I'm standing and I represent agents, and it's a two-part question. The first part is, I don't question that the adequacy of the providers in the network or the narrow networks on primary care or management of chronic care or that sort of thing. But when it gets to things that are at the level of pancreatic cancer, I know in my family I have two examples where one went to the regular provider and another went to a center of excellence, and one is no longer here, and the other is very viable. If when it gets to that level, if you would give folks some flexibility, that would be something that would actually make narrow networks more saleable from our standpoint. That's point number one. Point number two, on not the PPO, EPOs. If we actually work with our clients and we make sure the hospital is in network, and this is on an elective surgery or elective procedure, the hospital's in network, the surgeon's in network, everyone that we can identify by name or that sort of thing is in network. And they get in there. I had one example where the person leaned up from the gurney and said, "Everyone who's not contracted, get away from me." Were not contracted. So in an EPO situation, that person would actually have to pay that bill. Some sort of flexibility in that situation would be also.
Yeah, I think we are flexible in those situations, and I don't think that is EPO narrow network phenomenon. That is true in the broad full network issues as well. So that's not something I would look at as a narrow network issue. That is just a general conceptual issue of when you get in the hospital, non-contracted physicians actually assisting in a procedure. We try to be flexible in those situations. I would say, let us know about it if and when it happens. We can work with you and your client on it. But those are, I don't want to focus on a narrow network piece of that because I don't think that's a narrow network issue. That's just the general provider challenge.
Yeah, and if I could speak to that too, because in that situation where the consumer has done everything right, they know who the contracted hospital is, the doctors, the surgeons, and the other providers, the anesthesiologists, the pathologists, generally don't contract with managed care, and so the consumer shouldn't be held responsible for those bills because of that. But I want to just say. Yeah, but I'd just like to offer that if you have those situations, you should contact the DMHC Help Center, and oftentimes our staff can work with the plan and get those benefits paid as in-network. So.
Yeah, and to touch on the HMO versus EPO PPO issue, the HMO, it's a controlled, many times a capitated environment where the medical group is responsible for all the charges within those services or procedure. In the PPO environment, it's different, it's fee for service, or depending on who is providing the services, will charge. So that's a little bit different in how it's actually applied. But it's not a narrow network issue. It's just a PPO, EPO, general contracting issue.
Yes, sir.
Mr. Coleman, you mentioned that access to behavioral health is a huge problem for the consumer. consumer. It also seems to be a huge problem. I work in Medi-Cal and Medicare. I work with both the organizations. What are the plans for non-contract providers or the narrow networks when it comes to behavioral health providers, opening up legislation or contracting options for psychiatrists, social work, all sorts of.
I think it was both of us, or?
Yeah, anyone, or just DMHC and Blue Shield are where I'm directing it to, but what are the plans on the plan side and on the regulatory side?
Well, let me talk, the Department of Mental Health, first of all, they're talking about merging in the County of LA, Department of Mental Health, Department of Health Services. But what I see from a standpoint of Medi-Cal psychiatric care, one of the major problems is 50% is paid by the federal government, 25% by the state, and 25% is a county responsibility. And what I have found in the appeals is I've found our beloved county very difficult to deal with the psych patients and paying for the psych patients. I do not see the same problem when it's covered by plans. What I see the problem with plans is getting access and appointments when they need them, and regular appointments. I see the Medi-Cal program providers having a difficult time getting paid. So it's a complex issue. Another point I thought I'd, before Coleman goes, is there's another aspect to access that really troubles me, and that is covered California, as the exchanges have developed, are based on income. What happens, and there's been incident like this, a particular person, decent income, decent job, and loses his job in the economy, and the income drops. This individual now may have to go into the Medi-Cal program. Completely different program, different doctor population. That seems unfair because he's not necessarily Medi-Cal eligible from all the elements of Medi-Cal eligibility. It's a brief income respite, but yet he's got to be dropped out and loses whatever care he had. That's something that should be fixed. That's a fix that's needed. That's not a person that is normally in that, percentage of the federal poverty line that requires them to be in the Medi-Cal program versus covered California program. That's just, I thought of it while I was sitting here. I'm sorry. Yeah.
I appreciate, on the behavioral health side, I'm going to claim a little bit of ignorance as far as how our contracting works, where we are as far as, I'm not sure if you're asking about our access to care or.
I work in appeals also there as well, and I don't see a lot of payment out to providers, not especially non-contracted providers on behavioral health services. Actually, it's alarming how much they don't get paid. So I'm just wondering if there's any movements to improve that in the plan side or in the regulatory side, or if it's being addressed. That's just my kind of
Yeah, I would say, unfortunately, I don't have expertise on the behavioral health side. It's not an initiative that I'm working on in the individual market currently as far as one of our cost of care initiatives, but that doesn't mean we have an entire team focused on cost of care, making sure we have the appropriate adequacy of our network on behavioral health, on the medical side as well. So I can't answer that, as.
Yeah.
One of the problems, I'm sorry, one of the problems is that most of the plans carve out their behavioral health piece. So I'll just pick a plan. I'm not picking on, let's say, Cigna for argument's sake. I'm not picking on Cigna. I'm just saying that for mental health and certain types of clinical diagnosis, and they have another payor, or call it a TPA, a claims administrator, that monitors that. So that could be a particular difficulty in the payment of providers because of that particular carve-out, call it a carve-out.
So I don't know if your question was specific to Medi-Cal, but there was a change in the Medi-Cal program in the last year where historically, as George is saying, mental health services were carved out of the managed care plans, and the counties were responsible for that. That changed last year, and now the plans, the Medi-Cal managed care plans, are responsible for what they call sort of basic mental health services, and the more severe cases, serious emotional disturbances of child, et cetera, are still the responsibility of the counties. So, and frankly, it's taken the plans a while to ramp up because that requirement kind of was dropped on them pretty quickly. So they're in the process of doing their contracting with providers, and my department is evaluating those networks under an interagency agreement with the Department of Health Services to make sure that they meet our adequacy standards. But it's still a work in progress on the Medi-Cal side for sure.
I had a question both to Shelley and Colin about group medical. We talked a little bit about telehealth in this presentation, but in order for us, it's been an idea that we've been throwing out there. In order for us to increase access to our providers, where we can have multiple people in an actual medical appointment and give them an individual care and bill appropriately for that. That was something that education once to 15 people and teach them how to eat from a diagnosis-related group or something, like a diabetes education or something. But how does the insurance look and view on those claims? Because from a cost perspective, if we're throwing out, an increased number of claims, they're generally probably a higher level because the education piece could be, an hour long, but we're touching 16 different people. How is that viewed from the insurance? Be excluded from the narrow networks because of our higher costs and our higher levels, and how that would be tracked?
Yeah, I'll be honest, I'm not sure on the claim submissions, if you submit claims in bundles for multiple people, how we'll process them and how the payment and structure will work, especially if I understand it's a longer period of time you're working with these people. I'd have to take this offline with you and have you work with our claims area. Unfortunately, I just don't I won't know how they're going to process that, whether they're going to grade it up or down, or how they're going to work it through the system.
In the back.
You mentioned that Medi-Cal providers are finding, difficulty in getting reimbursed by the health plan. Do you have any insight as to what those reasons are?
Was it for me? I'm
for
sorry.
you, George. I thought you said Mr. Coleman.
I didn't hear the question at all. I'm not ignoring you.
You mentioned that Medi-Cal providers are finding difficulty in getting reimbursed by the health plans, or paid out by the health plans. Do you have any insight as to what those reasons are?
Why, you mean, why the Medi-Cal are not paying the providers?
Yeah, the health plans. Why are there getting difficulty in?
Well, several issues. There's technical issues which have gone bye-bye because some of the laws and regulations and case law in California. So technical issue would be eligibility, lack of authorization, things like that. Plans are not allowed to retroactively deny an authorization or retroactively deny eligibility once it's provided. The major issues we see are clinical denials based on level of care, length of stay, and medical necessity. And some of those issues are based on whether or not the patient should have been in the hospital 1 day, 2 days, or more. Level of care could be they should have been in a lower setting as opposed to an ICU, maybe a surge unit. And medical necessity would just be the services rendered. Maybe they could have been done in an outpatient setting or done, the patient could have been discharged earlier. These are the circumstances of the denials that exist. There's also contractual denial based on an interpretation of what the payment would be under a particular contract. I alluded to earlier about stop-loss provisions, which are provisions to hopefully the hospital will not have major expense or major costs when a principal diagnosis and/or maybe a secondary diagnosis will have the patient stay longer in the hospital than was originally expected, the hospital shouldn't sustain a loss. And there may be some provisions that allow the hospital to capture some of those costs for the length of stay, because they may be being paid a case rate, for example, for a particular procedure, and there was some outlier or some difficult situations with that particular stay. So those are the kind of denials the providers see on a regular basis.
Dr. Schweitzer.
Do health plans, either private or public, generally cover services delivered in medical clinics located in retail settings like the Doc in the Box?
If they're contracted.
And programs? Do they generally cover, or do they generally
It's hard to generalize some of those statements.
If they're
I think it
contracted.
depends on the
If they're
plan. Some
contracted.
do and some don't.
Yeah.
And we also contract with some of the retail clinics we would contract with. So, generally, it's hard to respond to the question. We are looking, other carriers, Anthem Cross, we look at retail clinics as an opportunity to get to more consumers. But it depends on the clinic, depends on the carrier.
Staffing in the doctor's office can be very expensive. Is there some way, between all the brain power that we have in Sacramento plans, that we can come up with a simpler system to get authorizations, which would make operation in the doctor's offices a lot more efficient?
Meaningful use?
I think I don't have an answer for you today. I think we probably could put our heads together and try to come up with a better process. I'm not aware of those lengthy delays in getting the authorizations through our system.
They seem to doubt
Obviously
you, Carl.
you are, so I'll agree with that. It's something I can bring back to our team, at Anthem to discuss. It's not an area I oversee, running an individual business, but it's obviously a concern for our provider partners, so it's something I can bring back to our team.
Isn't that a metric in pay for performance that, authorizations within a certain prescribed time, as long as they're not urgent?
Yeah, I'm not sure.
Is it?
I don't understand.
Right, Shelley?
I don't know.
Yeah. All right, so that one we'll work on. Any other questions? We have some more time. I can't believe you guys are out of questions. Ira, you got anything? Yeah, go. Right there.
Question for
Yeah.
Colin.
Yeah.
What percentage of your current California membership
Last one.
is currently in a narrow network? 2 years from now, what do you think that percent would be? And what parts of the state is Anthem focusing on in trying to satisfy their demand from clients for more narrowband network? I'm trying to get at the Anthem strategy.
Yeah, well, the first two questions are easy. 100% of our members are in, quote unquote, a narrow network.
And save this date.
Nice, but it's been-
February.